Good evening to all the viewers who are watching live and will be watching on a recorded version. This is me on the sheet, IT manager. We are on service on CME. Without wasting any more time, let's just jump to the success countdown time.
Good evening, sir, and good evening, all our viewers across the globe. And we are slowly and steadily creeping towards our century mark. Our online CME, Continued Medical Education Program, has been now tonight we are going to host 77th CME. And it's a proud moment for us that we'll be hosting tonight one of the very sought for speaker among the UG fraternity from NIH, the first batch of NIH. And with your permission, our beloved Kalyani sir, uh, let us call on our inaugurator tonight, who will be acting as the moderator too, Dr. Ashish Kumar Basu, to inaugurate tonight's session.
Good evening, everyone. Good evening, Dr. Kalyani sir. Good evening, Dr. Mukherjee. And today we are going to hear a wonderful topic from my senior, who rather guided me throughout my BHMS course, and a very reputed person in the fraternity of homeopathy, Dr. Partha Chakraborty, who is presently the visiting professor in the Department of Homeopathy at the Lincoln University, Malaysia. And he is having a rich experience of 26 years as a homeopathic practitioner. He practices in his own clinic at Durgapur, and he has a tremendous career of treating a number of difficult cases, including one which we'll be hearing from him today, brain tumor cases, and also many other rare cases he had went through, like the dermatological problems, allergic disorders, hyperlipidemia, various endocrinal disorders, and thyroidism, etc., and the musculoskeletal system, and even the anxiety, neurosis, and other things. And he was a very talented person. I had known him since my first year in NIH. He was a studious person and did tremendous records throughout his career. So let's come and join him to hear from him his experience with brain tumor cases. Welcome, Dr. Partha Chakraborty.
Thank you very much. Good evening, everybody. I pay my respect to all my teachers and to our respected Dr. Kalyani, who is present over here, who has been guiding us from the NIH days, and my good friend Dr. Bidyut Mukherjee, and my younger brother Dr. Ashish. Thank you very much for giving me a super introduction about me, which I don't think I deserve. Anyway, thank you very much. Actually, I've selected the topic as my journey with brain tumor cases. Why? Because this neurological cases has fascinated me from the very beginning in my career. I started my practice in 1996 in Durgapur, West Bengal, and I've been seeing these cases, brain tumor cases, since 2003, I remember. And from that time, I have seen many cases of brain tumor cases, many cases, and it has really been my journey with various types of cases. And one disclaimer I tell everywhere, over here also I must tell one disclaimer before I begin my presentation, that I have failed in more cases than I have succeeded in these cases, because these are very difficult cases. These are very, sometimes these cases become very scary for us to handle in our private clinic. Sometimes cases do often come to us in a stage where they require hospitalization, or sometimes they might be requiring hospitalization. In these type of cases, we have to handle single-handedly in our clinics. That becomes very difficult, becomes very challenging, becomes very strenuous for us. And it becomes all the more strenuous because this sort of cases can get relapsing symptoms, can get any sort of disease aggravation at any point of time during the treatment. And the patient party, what we call the relatives, the mother, the father or brother, anybody, they can call you at any time and they can just tell you that this is the problem. And over and above, in our private clinic, what is my personal experience in these cases is that these cases do often come from far away places. Sometimes they're coming from places around 300, 400 kilometers from my place. So these things have to be kept in mind. So it's a very challenging journey I'm having since 2003. It's still going on. I'm having many cases still under evaluation, and I'll be trying to uh, give a small lecture on this, on my experience that I have gathered so far. I have divided my lecture into three parts, whereby the first part of the lecture will be regarding a brief introduction about brain tumors. We might be knowing about brain tumors, but I have taken this opportunity just to, refresh our studies regarding brain tumors. I'll be giving a small introduction so that the pathological portion is clear to us before we go into the practical portion. And then management with homeopathy, I have given my own personal observations how to deal with these cases with our homeopathic medicines. And today I'll be giving two case illustrations. One I will be presenting an acute exacerbation in a chronic brain tumor case that I was treating. It's a closed case now. And the second case is a case which is still under evaluation. It's a very very novice case that has come just a couple of months back to me, and it's a highly malignant case, and I will show you the improvement today. So what is a brain tumor? It's actually an intracranial space occupying lesion. You can see the illustration over here on the right hand side, that it's a mass of tissue formed by accumulation of brain cells or by accumulation of abnormal cells. The brain cells can grow in mass, causing intracranial SOL, or abnormal cells in the form of metastatic cells. They can come from other organs like lungs or breast, and they can settle in the brain, and they can also form an intracranial space occupying lesion. So over and above, this intracranial space occupying lesion is commonly known as brain tumor. And these cells, these abnormal cells, or this abnormal growth of the brain cells, they are unwanted, but they grow and they cause problem. And symptoms vary based on the tumor location. Symptoms vary according to the mass of the tissue, according to the mass of the SOL, and the presence of the tumor where it is located. Now, brain tumors can be divided mainly into two types, broadly into two types. The first category belongs to benign or malignant tumors, and the second part is primary or secondary. It can be divided into benign or malignant, or it can be divided into primary or secondary or metastatic. Benign or malignant, they don't require any description. Primary or secondary, I'll just tell you. Primary tumors means the tumors which are growing from the brain tissue itself. In the brain, they are located primarily in the brain and they grow in the brain. Secondary means that the origin is somewhere else, and most commonly the breast. If there is a breast malignancy or there is a lung malignancy, we see that very often that these tissues, they migrate to the brain and they cause metastatic brain lesions. So these are the two two types, benign or malignant, or they can be classified according to their source of origin, that is primary or secondary or metastatic. Sorry. Now, what are the types of brain tumors? There are mainly four types of primary brain tumors. Primary, this word is very important, this primary brain tumors. This primary one is very important. I told you that these type of brain tumors, they are originating from the brain tissue itself. There are four types of primary brain tumors. The first and the commonest are the gliomas, which are originating from the glial cells or the brain cells. So they are known as gliomas. They are the most commonest. They are the commonest brain tumors that we encounter in our clinical practice. Second commonest type of primary brain tumor that we are seeing in our practice, they originate in the meninges. The meninges, they are located peripherally outside the brain, just below the scalp. So, if a primary tumor arises in the meninges, it's known as meningiomas. The third type of primary brain tumor, they originate from the pituitary gland, and they are known as pituitary adenomas. Pituitary adenomas, these adenomas are normally less than 10 mm in size, and if they grow more than 10 mm, then it's known as pituitary macroadenoma. Anyway, the pituitary gland, if they are having a brain tumor, that's known as pituitary adenomas. And the fourth type is primary brain tumors, which grow in the myelin sheath, that is nerve sheath tumors. So I've given a few illustrations over here. You can see this CT scan of the brain. This is a space occupying lesion. This is a brain tumor over here, and this is actually a glioma. It begins in the glial cells, and this is the most prevalent type. 78% of them are malignant. So when you are dealing with a glioma, just keep in mind that you are dealing with a very serious case. Second type, I told that it's a case of meningioma. This is the brain tissue, and in the peripheral region, there are three meninges we are having: dura mater, arachnoid mater, and pia mater. And this tumor can originate from any of the meninges, and this is called meningioma. These are located peripherally, just outside the brain tissue, and according to their location, they can cause symptoms. These are two illustrations of meningioma. Third, I told that the third primary brain tumors are the pituitary adenomas. If you look at this illustration over here, this is the sella turcica. The base of the brain is having a small cup-like bony structure, which is known as sella turcica. Over and above the sella turcica, the pituitary gland is located. And when the tumor grows in the pituitary gland, that's known as the pituitary adenoma. This is the white tissue, is the pituitary adenoma. If we look from behind, it is appearing in a figure of 8. It's known as snowman appearance. Radiologically, you can find the radiologists opine that snowman appearance can be obtained in cases of primary pituitary adenomas. And the fourth is the tumors that is arising from the myelin sheath tumor. Commonly, we are seeing schwannomas. In our clinical practice, we can see cases of schwannoma. They are all myelin sheath tumors, and mostly they are benign tumors. So these are the four types of primary brain tumors we see in our clinical practice. I've listed a few benign tumors over here just for your information purpose, of which they are the chondromas. Then we have got craniopharyngiomas. Today I'll be talking about the craniopharyngioma case. Then gangliocytomas, meningiomas, pineocytomas, pituitary adenomas, and schwannomas. Very recently, I'm seeing a case of pituitary adenoma. It's under evaluation till, and it's improving very much with TUJA. So these are the list of benign tumors that we clinically see in our practice. And these are the list of malignant tumors, of which the first and foremost malignant tumors is the astrocytomas. They are highly malignant tumors, astrocytomas. Then ependymomas, glioblastoma multiforme, GBM. It's in short, it's known as GBM, glioblastoma multiforme. It's also a very malignant tumor. Medulloblastomas, they are mostly seen in cases of children. This is the most prevalent pediatric malignant tumor that we can see in our practice, and the other is a rare one, oligodendrogliomas. So these are the list of malignant tumors we see very often practice. Now, why do the symptoms precipitate due to this intracranial SOL? There must be a reason. The first reason why we find symptoms in brain tumors is due to the increase in intracranial pressure, because the mass is increasing. There is an accumulation of tissues, brain tissues or metastatic tissues, and they increase in the mass, and as a result of which they exert an intracranial pressure, as a result of which we are having some symptoms from the patient. Number two, the symptoms can be due to the focal position of the lesion. If the tumor is located in the frontal part of the brain, it will produce some symptoms. If it is located in the posterior part, the occipital region, it will produce some symptoms. If it is located in the parietal portion, it will produce some symptoms. So the symptoms, the nature of the symptoms that we find in the brain tumor patients will definitely depend on the focal area where the tumor is located. And thirdly, the symptoms are also dependent on the functioning status of the tumor. What do you mean by functioning status of the tumor? Now, I just talked about you. One type of primary brain tumor is the pituitary macroadenoma or pituitary adenomas. Now, there's an interesting point to be noted in case of pituitary adenoma. The function of pituitary gland is to produce some hormones like TSH, LH, FSH, then this prolactin, growth hormone. These are the hormones that are secreted from the pituitary gland, which which go to the target organs, and the target organs function accordingly. Now, when there is an adenoma, when the adenoma is growing over the pituitary gland, what happens? The pituitary gland is producing or secreting the necessary the hormones, as also the adenoma can also, in addition to the pituitary, can also secrete more amount of hormones. So when the adenoma is active in producing hormones other than the pituitary gland, that is called known as the functional pituitary adenoma. So this functioning status of the tumor is also very important. If there is a functioning status of the tumor, so we will find the symptoms according to the nature of hormones. Say for example, I'm treating a case of pituitary macroadenoma right now in a male patient who is 54 years old. The case is under evaluation. I'll talk about that case in some other day if I get the opportunity. Now that patient, in addition to the pituitary gland, his macroadenoma is producing excess of prolactin. So it's a case of pituitary macroadenoma with hyperprolactinemia. And as a result of this excess prolactin, he is suffering from some symptoms of hyperprolactinemia, which is whereby he is having lack of sexual desire. There is a less amount of testosterone produced, as a result of which there is a lack of sexual desire. So these symptoms are produced due to the pituitary macroadenoma. So this is known as a functioning status of the tumor. So these are the reasons why we are finding symptoms in brain tumors. Now, what are the common clinical manifestations that we see in cases of brain tumor? These are the commonly symptoms, but they might not be present in each and every case. Just remember this thing. The commonest clinical manifestation in brain tumors is a headache. Headache is the commonest presentation, whereby the pain will be a constant pain, and the pain will be worse upon awakening. This is very important. Just after waking from sleep, the patient will be having an heaviness or a pain continuously continuing through the whole day, but that begins just after getting up in the morning. And this pain can be aggravated with sneezing or coughing. Whenever he is having some impulsive act like coughing or sneezing, he will have pain. Nausea, which is aggravated in the morning, or if there is a change of position, he might feel nausea. Even he might have episodes of vomiting, especially when the cerebellum is affected. And drowsiness will often be encountered in our practice, which is a later symptom. This is also another very common manifestation that we see in cases of brain tumors, that is diplopia, double vision. And in some cases, especially in pituitary adenoma cases, we find when when the pituitary adenoma exerts a pressure on the optic chiasma, it produces loss of peripheral vision. The vision in the left side or the right side can be lost by the patient. There can be blurred vision, where the patient will complain of difficulty to read or watch TV or see the mobile. and there might be difficulty in speaking, understanding, or writing. And last but not the least, there will be abnormalities in gait. The walking will not be normal. They will be deviating. They can they can walk straight. They'll be deviating while walking. So it's not exactly a paralysis, but in coordination, you can say, especially when direction of movement is concerned. So these are the common manifestations. There are some. This is also another common manifestation. These seizures. Seizures can be a presenting symptom also. Seizures can be a presenting symptom in brain tumor also. It can be generalized seizure, where the patient will be having seizure as a whole, or there might be single muscle twitching. This single muscle twitching we are often neglecting. The patient part is neglecting, but this is not to be neglected because this can be precursor to a brain tumor, and this can be a presenting symptom also. And very interestingly, this anosmia or loss of taste, they can be also some presenting symptom because they are all neurological symptoms and they can be presenting symptoms of brain tumor. And there can be some so far I've talked about the common clinical manifestations of brain tumors. I repeat once again that all the symptoms might not be present in every case. In each and every case there will be some symptoms out of these symptoms. So these are the common symptoms of brain tumor. There are some additional rare clinical manifestations like abnormal respiration. If it is affecting the tumor is affecting the respiratory center, there might be abnormal respiration. There might be systemic hypertension which will be uncontrolled. That can be due to this brain tumor. And unconscious is a coma. The patients will fall unconscious. The first case that I will be describing today, that case actually presented to me several times with this problem, unconsciousness. So far we have talked about this brain tumor. What is a brain tumor? What are the types of brain tumor? I have shown you some pictorial representation of brain tumor, and I have given you a list of common benign brain tumors as well as malignant brain tumors, and I have listed the clinical manifestations which we are commonly encountering with brain tumors. I hope so far this introductory part, the prelude, is clear to everybody. Now I will be entering the second part of my lecture, that is a management with homeopathy. Over here, I will be telling some points which I've gained in my experience over the years. Our primary goals, I've set in brain tumors, our primary goal should be to cure if possible. To cure if possible. What should be cured? Hahnemann has every time told that we have to know what is to be cured in the patient, and we have to keep this in our mind. What is to be cured in the patient? The disturbing symptoms, the presenting symptoms with which the patient is coming to us, that has to be cured if possible. Or the complications after treatment. Most of the cases in our clinical practice, we see that they go to the allopathic doctors, they go to the surgeon, they go to the super specialty hospital, they get all sorts of allopathic treatment, they undergo surgery, and after these complications they come to us. After medical complications, after surgical complications, they come to us, and we have to take those cases also, and cure we have to cure these cases if possible. And the second goal that I set in my patients is that to save and prolong the life of the patient. That's also our priority. If the patient is a malignant patient, we have to try to save or at least to prolong the life of the patient. If the super specialty hospitals, they give the lifespan to 6 months, if we can expand the lifespan to 1 year or 2 years, that is also our achievement with homeopathic medicines. And lastly, but not the least, we have to improve the quality of the life of the patient. When the patient gets better with our medicines, our aim should be to improve the quality of the life of the patient. So these are the primary goals in our treatment for brain tumors. And we must remember that all brain tumors are not life threatening or all brain tumors are not cancerous. Why I have written this thing? Because once we hear that a brain tumor case is going to come to our clinic, we get a little scary. This was my experience when I started in 2003 my journey. I was also I got scared when these sort of cases used to come to me. But over the years, with my experience, I have gained this experience that all the brain tumors are not life-threatening, not cancerous. So you think about the case individually. Always remember what Hahnemann has told, what he has guided. So over here also we have to think about the case individually, and we must not panic. We must not panic that a brain tumor is something which we are not able to deal with our homeopathic medicines. That's not the case. There are many cases where we will excel with our homeopathic medicines. Keep that in mind. And first decide whether the case in hand is critical or non-critical. This is very important. Whenever you have the patient in your hand, you have to decide whether it's a critical case or non-critical, because your management will depend on this thing. For effective homeopathic treatment, we have to focus on the following points. This is also, I've charted it from my own experience. The areas of focus I've divided into two portions. One is regarding the critical cases, the other is regarding the non-critical cases. In critical cases or acute exacerbation of chronic cases, acute symptoms are to be taken into consideration, especially the acute causation has to be considered. And remember, time is very short. We have to deliver very fast results in critical cases. Non-critical cases, they will definitely give you some space in regard to time. So you take details of the present case, including history of onset, details of the associated complaints and modalities and concomitants are to be noted. Detailed mental and physical journals are to be noted. Past personal, medical, and surgical history is also very important. Over here, I'll just give you one small example. The case right now, which is under evaluation, the case of pituitary macroadenoma. He came to me just 1 year back, 2022, but he had got a history of mental trauma around in 2012, around 10 years back. And that case, that mental trauma, that history was the beginning point, that was the opening point in my case. And I started that case with Natromule, and it had given me a very good result. Anyway, so in non-critical cases, you have to keep these points in your mind. Remember, finally, constitutional treatment should be initiated in non-critical or non-life-threatening cases, or when the critical period or the crisis is over, you can institute non-constitutional treatment, and in post-surgical cases, in order to prevent recurrence. Our our objective should be to prevent recurrence in post-surgical cases. So the second portion regarding the homeopathic management, what I have gained in my experience over the years, I have shared with you. Now, the third and final portion of my presentation today, I'll be presenting two cases today. The first case, was a case of brain tumor. Actually, I call this case as my bread and butter case. Why I call this as my bread and butter case? Because my journey with brain tumors began with this case, and after this case was cured, or after this case got a massive relief with our homeopathic medicine, I have got many cases referred from that patient. After that patient was cured, I got many referral, include brain tumors, cancers. I've got several difficult cases. So I term this case as my bread and butter case. So summary of the case was that this patient was suffering from a cystic tumor. It was located in the posterior fossa near the occipital region, near the brain stem. And initially they went to Bangalore to Nimhans, and they got it operated for 2 times in 2001 and 2002. Initially, these cases, they don't come to us. They go to the super specialty hospital, and they went to Bangalore to Nimhans. They got it operated. And again in 2003, the same symptoms began to resurface again. And they again went back to Nimhans, and the doctors, they very honestly told them that if we go for a third resection of this case, that results could be fatal. The patient might not survive. Why these are why these are reappearing? Because when they are operating the cases, they cannot operate, they cannot uproot the whole the tumor. They leave the stem, they leave the root, and that is the reason why these brain tumors, even after operation, they recur. We find it very often in our clinical practice. Now, after hearing this opinion from the specialist in Nimhans in 2003, the guardian, they decided not to go for operation, and they came to me. I was fortunate that that case came to me, and they came to me with the request that, doctor, whatever be the status of my daughter, just try to contain the recurrence of the tumor so that the tumor does not grow and we do not lose my I do not lose my daughter. This was the request by the father. Summary of the case was presenting a plain headache. I told you there is a commonest presentation. It's a continuous headache. The headache was very severe at times when the patient used to pull the hairs like with the two hands, and she was suffering from nausea and vomiting, especially with smell of food, especially smell of cooking of fish. They complained of anorexia, lack of proper balance. That means there was a difficulty in gait. The patient was very irritable, aversion to suggestion and advice. This thing was obtained. The mother told me that the patient is very irritable. Only she was around, I think, 17 years old at that time when she came to me. But she was very irritable and she was not heeding to any advice. And she was a boyish girl. She used to dress in jeans. She used to wear t-shirts around uh, how many years? Around 20 years back. And she used to like to play with the boys. So I've used the term boyish girl. And the treatment went on for many years. Various medicines were given in the long course of the treatment. I remember I began the treatment with natrum. Sometime in the course of treatment, natrum sulf was given because she had a tremendous exacerbation of the headache following a injury over the head over here. So natrum sulf had to be given. At one point of time, arsenic was to given because she had an exacerbation of the vomiting and nausea. Coniamac was given where the vertigo or the dizziness was very prominent, and in the later portion, just to correct her gait, because the problem was with the gait uh, in the later part of the course of treatment, I had to resort to plumbumate. So these are the medicines that I had to use in this case. It was a long drawn case, and due to the treatment with homeopathic medicines, now she is leading she was leading a normal life around 10 years back, since 2010, with a few acute paroxysms. And she was stable after starting homeopathic treatment. She was stable. She was having a few acute paroxysms of headache and some acute paroxysms of unconsciousness. Latest MRI probably was done in 2010. I could not show you because I don't have it. The patient part did not submit to me. But that suggested, I remember I've written down in my notepad that it suggested that the partially resected tumor has developed calcification, and due to the calcification, it's now in a residual non-enhancing stage. This radiological terminology, they are very important for brain tumor cases, that when the tumor is in a non-enhancing stage, we can be very sure that it has been contained. Now, I will be presenting one episode of acute stupor. In this case, I have faced several acute exacerbation where the patient came with severe headache, where the patient was brought to my clinic in an unconscious state. Similarly, one day in the year 2000, I'll be coming to that slide. She was brought to my clinic where she was suffering from acute stuporous condition. Female aged 30 years, unmarried, became stuporous and was dragged into my clinic. She was virtually dragged into my clinic by her parents. She was responding to the calls vaguely. I will show you the video. And there was absolute drowsiness which was noted while I was observing the case. The gait was unsteady. She could not walk properly. She was held by her mother. She had dual vision, complaining of diplopia. She had severe headache, pulling her ears. Now, when I asked her mother, how did this acute thing start? The mother told, might be yesterday evening I had a small quarrel with my daughter because my daughter was uh, asking to go for a picnic. It was December. It was December, and she was asking to go for a picnic with her friends, and I objected. I told her that you cannot go because you are not fully well, so I will not allow you to go with your friends for a picnic. So that was a big disappointment for the patient. Following a brawl, she had a verbal brawl with her mother, and following that, she had a disappointment, and that could be one of the reasons for this acute stupor. So, uh, before I show you the video, I am very fortunate to the parents that they allowed me to take the video. The first day of the acute stupor was on 24th of December 2013. Just see the video. You can see the head is lagging behind. She does not have the control over the brain of the head. She's lying in a semi-conscious state almost. Close, her eyes are closed. Orko, how can I fast forward this video? Okay, I can do it. See, the mother is holding the patient all along because she does not have control over her head. The head is lagging. I will just fast forward the case video. Sometimes she is responding, vaguely responding. Now I will fast forward this video. See how she is lying. She is lying just like a log. I remember the first time she came to my clinic when she was unconscious. She was brought to my clinic. That video I don't have. And to be very honest, I was very nervous at that time, but Carbovage at that episode, Carbovage saved my, uh, prestige at that time. After giving Carbovage, within 15 minutes, this girl regained consciousness. So this was the second or third episode that she was brought to me with these problems, and I was fortunate that the guardian allowed me to video record this case. So this was the first day, 24th of December. So what were the rubrics taken after the observation, after the case record? What are the rubrics I took? Mind excitement, excitable elements from aggravation. This is a causative modality, very important. There's a mind stupor, mind answers confused, mind answers slowly, and generalities. I've taken the generalities gait, reeling, staggering. These are the few rubrics that I took in this case. This was a reparation from Kent. The repatriation showed the first remedy that is coming is Helliboras. And phosphoric acid is a very close second. Helliboras is covering 5 symptoms, all the 5 symptoms having 19 points. And phosphoric acid is coming a very close second with 4 symptoms, 16 points. I prescribed on 24th of December Helliboras 30. Normally I give in distilled water. That's my way of practice. I give in distilled water just to avoid aggravations. And I told the parents to bring her back or report to me at least the next day after 24 hours. So 24th of December, Helliboras 30 was given to the patient. Now 25th of December, mark this day, second day, after 24 hours, the patient was brought to me. Just observe how she's being taken into my clinic. Now she's still having blurred vision. She's still having blurred vision. But walking is a bit steady in comparison to 24th. Now she can hold her head at least for some time. Yesterday she was not having any control over the head. She's wiping her eyes. So these things have returned, though she is still stuporous. Just observe. See, the pain reflex has returned. She was having pain when she put her head on the table. She pulled her hat down to avoid the pain. So these are good things. That the pain reflex has returned. Now I'll just move fast forward. The mother was describing. Still, she was having some headache because the mother told me that she was pulling her hairs when she was having headache. The mother is showing that she's having pain in the vertex and she's pulling the hairs like this when she's having pain. So this was the second day. There was an improvement. She arrives much better, still having blurring of vision and headache, but she's responding to normal calls. Follow up. No need to hospitalize the patient, contrary to common people's notion. So in these sort of cases, people they rush to the hospital. They take these patients to the hospital, but these parents of this girl, they insisted upon me. They insisted to be with homeopathy. Now Helleborus within 24 hours responded very well, and after this 24 hours was gone, after the acute phase was slightly overcome, I decided to come to the main drug which was required at this point of time, that is ignatia. And on 26th of December, I'll show you the video after this slide. 26th December, just 48 hours after the acute stupor that she was suffering, she arrives much, much better, walking almost alone without help, you will observe. And she's laughing. Mother is also smiling and she's also smiling. This social smile, this smile is a very good response or very good assessment for us when the patient is improving. See, this is the video on 26th. She's smiling. She's sitting comfortably. She doesn't have the blurring of vision. She's sitting straight without any support. Now, for the first 2 days, she was not looking. She was keeping her eyes closed. Now she's looking. She's normal. Within 48 hours, she has become normal with homeopathic medicines. So this case actually has given me a lot of confidence, and I've shown this case earlier also to my students, so that they can have this confidence. She sneezed. One thing you observe, she sneezed, but she doesn't hold the head, so the headache has reduced. So I'll move a bit fast. Okay, so this was the the case that I intended to show you, an acute stupor in a case of brain tumor. The brain tumor case is a closed case now. Now I have given a summary of this case in 2023. The status, it's a closed case now. I'm not treating the case, but I'm having a close watch on the case because many of our family are my patients still now. She is still surviving, leading a normal life, no complaints of severe headache and diplopia, and guardian are willing. But there's a point which I must mention, that in spite of several requests, I have requested the guardian, please do an MRI so that I can see what is the status of the tumor. But still, they have not responded to my requests. This happens to us in our clinical practice. Many times the patients are unwilling to go for MRI because they are costly. They don't want to undertake an MRI, and we cannot compel them also. We don't have any choice in these cases. So this was the first case of a brain tumor, which is a closed one now. It has improved, and I showed you one acute exacerbation. Now this case is a very recent case. The second case, the last case of today, second case, the case of diffuse midline glioma. This is a very recent case that has come to my clinic. Now, before I go to the case, I'll just tell you a few words about diffuse midline glioma. DMG is usually found in the midline structures of the central nervous system. It's found in the thalamus, brainstem, cerebellum, or spinal cord. The name midline itself, shows that this structure is located in the middle portion of the brain. So this is known as diffuse midline glioma. You can see the picture. The common presenting symptoms of diffuse midline glioma is diplopia. Diplopia is a very common presenting symptom, problems in swallowing, cannot swallow food, and weakness of one or both sides of the body, weakness, loss of balance. The gait will be unsteady, the loss of balance. And regarding prognosis of DMG, the prognosis is very bad. This type of tumors uh, carry a very, very poor prognosis because they are very aggressive tumors and they are classified as grade 4 tumors. And this DMG diagnosis is a very recent diagnosis. This term was coined in 2014, most probably. Very recent coinage of the term has been done. So this case carries a very poor prognosis. Normally, when these cases are diagnosed, from the diagnosis date, they survive for 1 year. Date of first report, 7th of June 2023, just 2 months back. The patient was non-ambulatory and the patient was not brought to my clinic because the patient could not be brought. They stay around 200 kilometers from my place. Father and uncle came with the reports. History, I got this history. 14 years old, male child, schoolboy. Patient is bedridden at present. Now in March 2023, he was taken to Nimhans, Bangalore with the following symptoms. He was vomiting incessantly. There was acute headache and weakness of the lower limb, in the four limbs, the two hands and two legs, and there was imbalance while walking. With these complaints, he was taken to Nimhans, Bangalore. Now, in Bangalore, an MRI was done in March 2023, where it was shown that there has been a lesion in the pons, and that lesion was showing extrapontine extension. That means it was creating an intercranial tension. It was creating a pressure, external pressure over the extrapontine tissues, and the biopsy in Nimhans that showed it's a case of diffuse midline glioma. It has been given. So this was the MRI report. The report was not at all good, and the doctors over there, they were requested by the patient party to conduct an operation, but the doctors, they told that we cannot operate this case. The histopathology report was like this. You can see the section shows an infiltrative glial tumor showing neoplastic astrocytic cells dispersed in a fibrillary background. So it is actually over here, the final impression you can see diffuse midline glioma. And this is a variant. This variant is also very bad. So histopathology report is also confirming with the radiologist report that this is a case of diffuse midline glioma, which carries a very bad prognosis. Now, After coming back from Nimhans, this boy had again an acute aggravation of all the complaints, and he was taken to Tata Medical Center in Kolkata in May 2023. The final diagnosis in Tata Medical Center was also the same diffuse midline glioma, and he was advised and given radiation therapy. He was given 31 cycles of radiation therapy. Following radiation, immediately after radiation, he was discharged from the hospitals and the acute symptoms subsided and he was discharged from the hospital. I'm having that picture also, but I couldn't show you anyway. But during the course of radiation, he developed some dermatitis. These are the complications: partial alopecia, papules on the face, and mucositis grade 1. These are some of the complications that he had while he was undergoing the radiation. And this was the prescription from Tata Medical Center. You can see, if you go through the prescription, the time is very limited. This prescription, I found that it was just beating the bush around. They were not touching the main thing because they don't have any medicine for this. So it was a tangential prescription. They gave some anti-allergic, they gave, antifungal, they gave a steroid, they gave an antiemetic drug, but no drug was given for the main thing other than the radiation. So this was the prescription. Now, after 7 days from discharge from the hospital, the acute symptoms flared up again, and the patient was bedridden. And at that point of time, that the patient party, the father and the uncle, came to me. I noted these symptoms: severe weakness in general, weakness of the legs, cannot move. He was totally bedridden, was lying in the bed all the time, hungry but cannot eat because he cannot swallow. That's a very important symptom in diffuse midline glioma. Presenting symptoms in addition to the other symptoms while eating, here he was having cough followed by vomiting, salivation, constipation was very severe, and speech was mostly unintelligible. Constitutional symptoms: I got desire for fried egg, chicken, fried food, salty food. He had constipation where there was irregular and hard stool. He was academically moderate and was studying in school when he started suffering from this problem. Past history: he has got a history of convulsion 2 years ago, at 2 years of age. Remember, I cannot show you the first day picture because the patient was not brought to me. The father was requesting me to save his son because the TMC also gave a very poor prognosis, and I could not connect with them because they are staying in a remote village. No video was obtained in the first day. I did a repertoration with the presenting complaint, and you see plumbum metallicum. This is plumbum nuts, phosphorus. They were the front grade drugs that were coming, and I chose plumbum metallicum because plumbum metallicum features were uh, were very akin to the features that the patient presented to me. So plumbum metallicum was given. My objective in this case, given the present crisis, I told that this is a very critical case. So first, my objective was to save or prolong the life of the patient. And if the patient is saved, then I have to improve the quality of the life of the patient. Prescription Plumbamate 6 was given. Along with that, Calcreaflow 3x in biochemic, it was given. Second visit, the first visit was on I think 7th of June. 7th of June, and the second visit was on 23rd of June. And the patient came in my clinic along with his parents. Now the report from the mother: her son was much better. Stool, he is passing regular stool, and now he can swallow and he is eating food. Cough during eating is less. These are the reports from the mother. Patient, now he has no confusion. He can narrate his own story, and patient speech is intelligible. I will show you the video. Now there is a slight weakness of the left leg. Walking is still a little difficult. So there is a slight difficulty in gait. And couple of old symptoms were returning. He was complaining of sudden palpitation and sudden tachycardia he was experiencing, which he experienced earlier also. Now see the video. This was the first part of the video in my clinic. This is the boy. This is the boy. Patient was still weak, needed support to be raised, needed support while walking,
Patient
and
was
gait
still
was
weak. Needed support to be
sorry,
raised. Needed support
sorry.
while walking.
Okay, gait was still unsteady. See the second video. He is entering my own consulting room. See how he's entering. Slightly having some difficulty in balancing himself. The mother is holding on. So he is understanding and he's complaining with the commands. I told him, you come over here, you lie on the examination table. So he is understanding and he's complaining with the commands and instructions. So this was the second video of the second day. And now you'll see, interestingly, he's operating with a mobile. He's having weakness, still he's operating the mobile. Precise movements by the hands has returned. Precise movements by the hands has returned. Operating mobile on his own. He was actually sending his own reports from his mobile to my mobile. See how he's sitting, very typical position. He's smiling, that means he's better. The social smile is very important in assessing a patient's improvement. So this was the visit when he came to my clinic physically on 23rd of June, much improved. So achievement so far, a hopeless case, severely critical, suffering from a highly malignant tumor, has immediately responded to homeopathic medicines. Thanks to our father Hahnemann, the first challenge is over, and if he survives with our medicines, it will be a miracle, definitely. Subsequent evaluations, I will show you two videos, subsequent video evaluation. These videos have been shown, sent by the father to me. There is a third video evaluation on 14th of July. See how he's walking. Walking confidently without support. Gait is almost normal, and slippers are not slipping from his foot. He's walking in his own village. Taking a long stride. That's very important. Slightly deviated, taking a long stride. So he walked continuously for over 2 minutes, carrying a tumor in the head. So this was a third evolution. So our observation over here, walking confidently without support, gait is almost normal, slippers are not slipping. Plumber met. And this is the fourth evolution, the last evolution that I'm having so far. He'll be coming very shortly to my clinic. he's he's conducting his daily activities confidently. It's not a, he's doing his own household works normally and independently. He's still on plumber metallicum, getting up and going to wash his mouth. See, he will be doing everything on his own. So this is what we want in a patient. The patient must, the quality of life should improve, and so far it has improved. The symptoms are missing. He's eating normally. There is no difficulty in swallowing food, which is a very essential symptom of diffuse midline glioma. I'm thankful to the parents that they have shared the video with me so that I can share with everybody. And the confidence regarding homeopathy can increase, that we can do many things. His father came to me last week and he told me that he will bring his son this coming week. So this was another case, very recent case, still under evaluation. Summary, this case is still under evaluation, overall improving despite the poor prognosis. And we should not think about the poor prognosis. We should move along. We should work according to the instructions of Hahnemann, that we should individualize the case and try to work according to the instructions of Hahnemann. This patient is leading a normal life and no complaint of headache so far till now. So this was 2 cases that I presented today along with the introduction about brain tumor. Thank you very much. Hope you enjoyed it. Over to Orko. Orko, can you hear me? Yes, Dr. Ashish.
Yes, Dr. Partha, it was a excellent presentation I have ever heard. Your presentation started with the pathophysiology of brain tumor, and it was nicely divided. As you have divided the cases into critical and non-critical. The first part, the knowledge about the disease, was very, very effective, and you narrated the details excellently. The scope of homeopathy in these cases of tumor it was a very knowledge sharing for us, for your juniors who are striving to treat these difficult cases in today's scenario. And as you state, homeopathy in the aspect of improving the life expectancy and palliative and the palliative part, if not cure. Although the target is cure, as you have stated, we are targeting to cure the cases, but at least we shall improve the life expectancy and the life of the patients. Their regular activities. As you have stated in the last case, the patient is taking brushing his teeth with his own. He is doing all the household works. And this improvement of life is what we must give. We must try to give to the patient. Excellently, sir. It was a very good presentation. And the cases you have narrated today, the first case of it was a cystic tumor. As you have narrated, it was your bread and butter. And
Yes.
in the upcoming days, it will be our bread and butter and the bread and butter of all the fraternity of homeopathy. If they can follow your instructions, follow your what you have done in these cases. And what I would like to say you that the way you have followed the classical homeopathy, the system which has been narrated by our master, the repertorization and getting a pool of drugs and selecting among them. As you have said in the first case, you have got a pool of drugs of natramure, natrum sulf, arsenic album, conium maculatum, and plumbermate. And you also have described that when you have applied these medicines, with what symptoms. And we are really educated. We got educated further with what you have represented today. Only one thing I would ask in the second case, uh, the case of this,
Diffuse midline
uh,
glamour.
midline glioma. You started with cover I think. The first
No,
day when it was a very serious
no,
condition.
no, no, no. Actually, carbovage I gave in the first case.
At the first case, that's it.
First,
Yeah, yeah, yeah.
first case. First case
The
actually,
first case there was a serious condition.
yeah. That condition I could not record in the video because you can understand that these cases when they are brought to our clinic, it's a very critical. All the relatives they're coming,
Yes, yes.
and you cannot video record the case in a clinic. That's virtually impossible. Still, I'm obliged to my patients that they are allowing me to record these cases. So in the that first case when
Just can you
she
please?
was, yes.
Hmm. Can you please educate us in which condition you prescribe and why you prescribe carbohydrates?
Yeah, that case I remember. She was actually virtually brought to my clinic just by this thing. She was not able to walk. She was totally unconscious. She was brought to my clinic, and I got the history that she had a good feast yesterday night, just the night before that incident.
Okay,
And while I was examining the patient, I could find that the whole body was almost cold, and
okay.
she was having a constant eructation. There was a constant eructation.
Acha,
So I could
acha.
remember the teachings of Mathematica, that serious case,
Hmm.
life-threatening case, and there was bloating of the abdomen. So naturally,
Right.
Carvovage came into my mind, and to be very honest, I prescribed Carvovage 1M. I remember because at that time
Very
I
good.
was reading, the book of Dr. Douglas Borland. If you
Yes,
go
yes.
through the Dr. Douglas Borland, he
Boland.
actually showed how to give high potencies in acute cases repeatedly.
Absolutely.
Douglas
Yes.
Borland. So I was
Uh-huh.
following his dictum and I gave Carvage 1M, and I got a
Hmm.
tremendous result. Within 15 minutes, that patient sat up and she went back from my clinic. And the other patients, those who were waiting, they were actually awestruck that this patient was brought in the labs and now she is walking back. So this is the
Excellent.
beauty of homeopathic medicine. And this
Excellent.
diffuse
Yes,
midline glamour, I started with Plumbermet from the very beginning.
yes, yes, yes. And then the plumbermate and then
Can
in the second case you started with Helleborus.
No, yeah, the second episode of the first case
Second.
that I video
Uh-huh.
recorded, that was
Right, right.
Helleborus.
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 And the one thing is very important that you used 1M, that we have learned from our seniors, from our teachers, that more the symptom similarity matches, you strike with a higher potency,
Yeah.
and also in the acute cases too. And that we have learned today also practically from your presentation, from your clinical experience.
Yeah.
Thank you
Thank
so
you.
much. And in the second case, you use Helleborus followed by Ignatia, and there was a real cause for that. The girl was not allowed to go for a picnic, and there was excitement with her mother,
She
and
had a quarrel with the Ignition.
you excellently used Ignatia for that. And most important, the third one, which you are treating now, the case of DMG, and we have seen in the video how the boy is now walking, now doing all the household works, and taking tea and taking the cup and again putting it down. It was
Yes.
really excellent. It was
Very
really
effective.
excellent. And you have selected Plum Mate with Calcarea Floor. It was the first prescription, I think.
Yeah.
Now, why
That's
you can you please educate us why you use Plum Mate in the lower potency? Why in the Plum Mate in the sixth potency?
low potency. The reason is that this is a case which is having a very poor prognosis. It's virtually
Right.
a malignant case, and in
Mhm.
malignant cases, it's according if you follow the 12 observations of Kent. Uh,
Mhm.
so we have to resort to low potencies to begin with these cases because this is a highly dangerous case which can deteriorate at any moment. And
Right.
if I am allowed to quote from Kent, Plumbamet,
Mhm.
why did I give Plumbamet? If you go through
Mhm.
Boric's Mathematica or even Kent's Mathematica, you will find that all the symptoms that I have noted over here, they
Mhm.
are similar to this plumbum poisoning. This plumbum
Mhm.
poisoning, they are producing this sort of paralytic features. The
Right.
limbs will be paralyzed, the swallowing reflex will be gone, the speech will be
Mhm.
gone, and everything was found in this patient. The symptoms were totally matching with plumber metallicum, and the repertoration
Right.
also pointed towards plumber metallicum. The
Yes,
first
exactly. You have shown in
was
the representation.
the first drug was lachesis, second was plumbermet, but all the features were of plumbermet. So I gave, and in fact, plumbermet is a very good drug for brain tumors. Plumbermet and plumber iode also. In
Yes.
the case of MND, recently I'm treating a case of MND which has come from Noida district. I'm giving
Mhm.
plumamide to that case, and he's
Can you
responding
please
slightly.
explain what the Can you please say, educate us what are the indications for using plumum iode instead of
All the
plumamate
all the features of plumum along with hot patient.
on hot patient? And
Yes,
increase appetite. Increase appetite.
actually that patient, MND patients, they cannot swallow food properly, so there is
Swallow
no
food.
question. Yes, their
Appetite. Yes,
appetite is
yes.
very good. They're taking, the food is being grinded in the mixer, and they're taking very
Mm.
less amount of food.
Okay.
I will,
Excellent,
hopefully I will
sir. It was
that response.
yes, 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 yes. It was the three cases that we have seen today. Those who have observed today's session and those who will follow later on to the recorded ones. I think it will be very helpful to all of us who are here in the homeopathic fraternity to deal with the cases which we generally fear of treating in our clinics, and we really try to avoid the cases and for the fear of failure. And
Yes,
today's lecture, what you have showed us, actually not only the cases, your approach towards the cases that have educated us that how should be our approach to these cases. That
thank
was
you
very
very much.
important. That was very important because nowadays we see many honored doctors using certain drugs which should not be used. But you have followed the classical way and the way it should be followed according to the homeopathic principles. And when required, you have used the higher ones. When required, you have used the lower ones, the triturations, and that is actually the path should be shown to the juniors. Thank you so much, Dr. Chakraborty, for your wonderful presentation. We are enlightened. We are grateful to you for this lecture.
Thank you.
Over to Dr. Kalyani, sir. Please to do the narration.
presentation by our brilliant scholar of alumni, Partha Chakraborty. You see, all of us know that to get a case of brain tumor is not an easy job. It needs few years of practice. Either you get it accidentally or after gaining serious lived experiences, people refer brain tumor cases to us. So it's very rare opportunities. But it's a great opportunity definitely. What we have seen from Dr. Professor Chakraborty that yes, we can cure acute manifestation as well as the chronic pictures. It is very clear to all of us that conventional system of medicine, they can easily take out the neoplastic growth, with whether it is malignant or benign, by scalpel and scissor, by operation. But there is no instrument, no treatment available other than homeopathy, which can take out the cause of that neoplasia. Taking out of the neoplasia is definitely a management, one type of treatment. But treating the cause, the root of that neoplasia, definitely it is wider range of assistance medication that only homeopathy can do. That we had full confidence from our college life. In Calcutta Homeopathy Medical College, we have seen in OPD and IPD brain tumor cases. At that time, investigation was not that much so common. Usually, patients used to come from other hospitals, either being referred that a refused case, go to some other hospital, we can take trial of homeopathy. Because at that time, we had many allopathic doctors of different medical colleges in Calcutta Homeopathy Medical College, or by getting refusal from other systems, he used to come to our OPD. We have seen in OPD, IPD, improvement of brain tumor cases by our respected Dr. Park, Dr. C.P. Mundal. That's why from very beginning, in the early life of our homeopathic practice and teaching, learning, that brain tumor cases are not a scaring disease to us. Obviously, it becomes scaring when it comes in a personal chamber, private chamber, because there is challenging disease which we cannot cure or control. There are chances of detaining, and at the same time, patient will be disheartened. We will be also disheartened. But dear brothers and sisters, it is sure that homeopathy may be rarely, may be less in number, but can definitely completely cure brain tumors. And obviously can reduce active reservations, manifestation, lengthen life, future life pattern, improve life pattern. Definitely there are a number of evidences. Let me tell you my experiences in mathematics of homeopathy. Though I was more busy in joint disease higher than other diseases, I got one meningioma with a definite history of trauma by Necton's heart, and after by CT scan follow-up, it was evidently proved. If I get chance, I will show you later on that meningioma can be definitely improved and completely cured by homeopathic medicine by simply Necton's heart by getting a history of trauma in a little jar of 30 years old. Another thing I want to tell you, as Professor Partha was telling, that there are failures, definitely. Obviously, those failures are pillars of success. The more he got failures, the more he can become encouraged to fight with this type of brain diseases, brain tumor diseases. I will tell the recent experience in my locality. That boy was from birth, he had brain tumor, glioma, extensive glioma, and he had infrequent fevers, violency in every moment, irregular lifestyle, and incidentally, he asked my help. I got the history, and getting the history, I started the sterilization from lower gradually higher up. But I found that the patient is gradually improving to the extent the fits has come down, gap between the fits, the gap of days are increasing, violence of the patient is reducing, patient is gaining weight, sleep is little bit better, he has complete insomnia. But the case was no further improvement. Case was static for months together. He waited. Then ultimately I told him, do one thing, you go and consult with Bangalore Institute of Neurology if they can help you better from this stage. So by listening my advice, I was I am really sorry for my lack of knowledge that I could not wait a lengthy period once the cases has become stable. The case went to Bangalore Institute of Neurology. They arranged the operation and told the patient, we can try, but there is no assurance. Even that is life-threatening operation. They operated, operation was successful as per them. Patient came back to his home with little bit of changes, not absolutely normal. After 3-4 months, again the similar complaints gradually started cropping up and became more violent, more frequent fits, completely unable, completely disabled. Now his body weight has increased maybe due to steroid. Now the boy has become so much bleeding that it has become very difficult by the parents to move for toilet, urination, stool, eating, everything completely dependent. Just imagine, grown up boy of around 13, 14 years, he is completely dependent on his parents. Every time he is being carried after the operation. Why I am telling my idiocy that in homeopathy, if we find that in incurable cases or serious cases may or may not be syphilitic, once the case is static, neither improving nor aggravating, you should go on waiting, unless the case invites repetition of the medicine or higher up or any other accessory medicines. I'll tell you one example. After getting this failure, I recalled my memory. Few days before, I told it in one CME, Dr. Mahendra Singh, father, present director, was Dr. Subhash Singh. He used to go regularly to the chamber of Dr. B.K. Bose. Why I'm telling how long we have to wait? There is no limit. He used to go in the B.K. Bose chambers regularly. So one day, Dr. B.K. Bose went for a call, and Dr. Mahendra Singh was in his chamber. One patient came with a persistent ascites for a long years, and Dr. B. Bose prescribed Apis mellifera 6 with placebo for last 6 months. Just imagine. Not a matter of joke to keep the patients of giving 6 potency and waiting for 6 months. Every time patient used to come, Dr. Madhusan used to know the patient. Every time, every month, he will come with a big abdomen, all other pictures of the ascites, sunken eyes, hepatic faces, and he will say, no, doctor, I am not getting any improvement as I am before. No change. Dr. BK was simply used to take the prescription and write placebo and go, come after another 1 month. This was going on for months and months together. So that day, Dr. BK Bose was out of his chamber. Dr. Manju Singh was there. Then patient party requested, sir is giving same medicine, minimum for months together. Patient is not getting any improvement. Can you give something? Is that patient needs some change of medicine? Then Mahendra Singh, being encouraged, and he found that probably Dr. Basu, Dr. B.K. Bose has ignored or he has become indifferent to the cases because he's not curing. That's why he's not giving any medicine. He gave Apis mellifera 31 days. And the afternoon, when Dr. B.K. Bose came back from his call, Dr. Mahendra Singh reported that ascites patient came. He was given Apis mellifera 6 months before. I have given him Apis mellifera 30 one day. Then Dr. B.K. was suddenly started shouting. You have given him 30. This was told by Manjusham himself in our class to emphasize what potency is, how long you have to wait, what homeopathy is useful. Then he started shouting, you have given 30 without asking me. And Dr. Mahendra Singh just put it down, sir, I have given because I thought 6 months is maximum. That's why I have potency. Then he is asking Dr. Mahendra Singh, he will come tomorrow morning. And Mahendra Singh told, yes, sir, I will come. Oh, please come. See the confidence of a doctor. See the efficacy philosophy of homeopathy. Next morning, Dr. Mohan Singh, as usual, went to his chamber and the patient party came, not with the patient, with white dresses and that thing on the neck. That he has expired last night. Then he asked, Sir, my father has died yesterday night. I want one medical certificate. Then Dr. Bose simply told, you go and take the certificate from him. Mandro, give him the certificate. Sir is sitting in the class. That was a weeping in my back. That's what blunder I did. What dangerous thing is changing of little bit potential in serious disease. Sir could wait 6 months. I could not wait for even single day to ask Dr. Bose to give higher potency. This is homeopathy. So how long we have to wait? What potency we have to give? As Professor Chakraborty shown us, which potency we need at that time needs. How long we have to wait? When we have to change? This philosophical vision we should develop. Otherwise, we can bring our failures, we can be disheartened if we ignore homeopathic philosophy. That's why brain tumor is not a new thing to us. Like other tumors, in the similar process, take the cases, see, evaluate, as you have seen from this brilliant presentation today, get a repertory, bring out the drug, confirm it, consult with the mathematical, give it and see the beauty of homeopathic medicine. So, brothers and sisters, it is my earnest request to all of you, whoever has treated brain tumors, whoever is trying to improve the status or lifestyle of the patient of brain tumor, please come forward, send us for our publication, bulletin, our journal, e-journal, or you share with us by our WhatsApp to encourage our confidence that brain tumor we can equally tackle if we get chances. Anyway, this is presentation. Thanks to Professor Asish Basu,
Thank you, sir.
all other viewers, and those who will see later on. Thank you very much.
Sir, one thing I want to add, sir. As we have said in these cases, sir, the 12 observation, as Dr. Partha also said, that while selecting the
Your
potency.
voice is not clear. Doctor, can you clear the voice, please?
Hello. Yes, sir.
Come on.
Am I audible?
You are
Yes, yes,
audible.
Yes,
sir.
yes,
Only
you are
one thing,
audible. You are audible.
as Dr. Chakraborty also said, that the following 12 observations, I think, will be very important for us in treating these cases.
No, voice
Yeah.
is not clear. Not clearly audible.
Hello, 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 hello.
I think sir is having a problem with the internet.
Maybe. Partha, am I audible?
Yes, clear, loud and clear.
Yes. What I just wanted to mention that sir is also here. I think sir has left.
I think there's a problem with the internet.
Maybe.
Yes, sir is entering.
Yes.
Maybe.
Yes, sir is back. Sir is back. Sir, only one thing I wanted to emphasize that along as you have stated in these cases, in the last case where after using the higher potency the patient expired. I think the use of the following of 12 observations is very important in these critical cases, and in all the cases, and especially in these cases, we must follow the 12 observations.
Definitely. 12 observation
Yes.
is our parameter of improvement of prescription.
Exactly.
We should be
Sir.
very much careful about this. If
Exactly.
anybody asks what will be master, it is 12 observation will tell you.
One thing can I
We
add,
should
sir?
continue to wait.
Yes.
Yes, sir.
Definitely.
Yes, Partha.
Actually, we are very much indebted to Dr. Odhikari because
Yes.
we have got a
Exactly.
teacher like Dr. Odhikari who taught us in the class what are the different observations and how they're
Exactly.
imparted in our clinical practice. I am really I've learned at his golden feet that these things, and I've implemented in my practice.
Definitely.
And we have got teachers like you, sir. Thank you very much. for what we
Yes,
are
yes,
doing.
sir.
You are the
We
resource.
are blessed. We are
Absolutely
blessed to
correct.
be taught. Sir, we are blessed to be taught by you, Dr. Adhikari and Dr. Sarkar. And whatever we are here today because of you all persons, sir.
Yes, definitely.
Not by the Almighty and Master Hand. One more thing I want to tell you that is develop the practice of showing the 12 observations in IPD cases that we have seen. All the 12
Right.
observations we have not only heard in the past, we have seen in IPDs and OPD.
Yes, yes,
We used
yes.
to
Exactly.
say
Exactly.
this is
You have
observation
showed us in the clinic. Yes.
by doing the TB. That is to develop the practice of following the philosophy. Then we will get the real taste, essence of homeopathy. How beautiful it
Yes.
is.
Yes, sir.
Thank you very much.
Excellent discussion, Dr. Partha. Thank you, sir. And this is the power of the United Front of Alumnus of NIH. Come forward, share the experiences, and let us help each other to help themselves. That's the most important thought, what we all are thinking since the inception of this institute. Humble request, as our beloved president had said, I'll request Dr. Partha, Dr. Ashish also to submit your successful cases or failure cases in our e-journal Saturday Audi, so that on that peer review journal it can be published and it will be there on the online platform too. We are trying to gather few cases and few articles from our 77 episodes thoroughly. And our humble request to the viewers who are viewing it now live, or those who are going to view it in the coming days, as it will be there in the YouTube, Facebook, and Twitter platform, that please, if you have any questions relating to this topic which has been discussed, ask it in the comments, not on the apart from the topic. So it will be easier for the speaker to answer on that relevant topic. Moreover, for National Institute of Homeopathy Alumni Association is planning to have their alumni meet of 2023 in the month of December, awaiting the permission from our respected director, sir. Uh, Once the permission or any communication is received from that part, it will be informed through all the alumnus. Till then, we will be waiting for our 77th, 78th episode
Eight.
on, on 27th of August. And we need our alumnus to come forward instead of Kalyani sir, Ashish Basu, Om Priya, Chandrasekhar Pore, and other members, Kishore, that please be a speaker on the platform. So please be bold enough to come forward. And we want to see more cases after next 6 months. Dr. Partha, it's a request to you. Give us your date on the progress of the third case on your convenience before August 24, before 12 months. The date will be of your choice. What
Okay.
do you say,
Sure,
Ashish?
sure. Sure, sure. We want to hear more from Partha. We want to hear more from Partha. There are many cases he has cured, and we want to hear more from him.
And we are very unfortunate to miss Dr. Professor
And
Rajat Khan
not only
tonight. Bolo Ashish,
yes,
yes,
yes.
please.
Now,
Uh,
one thing I want to use this platform is not only for the cases we have treated and cured, and also the cases we have failed.
right.
There are the many cases we have failed, and if we can prop up the cases we have failed, I think our seniors and our teachers can guide us that you should have done this to this case. You have not done this one correct. That thing will be more useful, I think, to the juniors and for us also. that will discuss with the failures.
Sure, sure. We are trying to encourage our
With
juniors
permission of Dr.
accordingly.
With permission of Kalyani sir, obviously.
Sure,
Definitely,
sure.
definitely.
Sir is guiding us through and through. And this continued medical education program is only possible because on the other side, Dr. Kalyani sir is there. Otherwise,
Yes,
it's
yes,
That is
very
obviously.
big
we
teamwork.
all of us are doing.
Really.
It's a
We are
teamwork
grateful to you,
but
sir.
Really,
under the
definitely.
guidance of Kalyani sir. Tonight we are missing Professor Rajat Pal, who had
Yes.
been attending his brother, ailing brother, who had met with an accident. We miss you, Professor Rajat, and we expect a speedy recovery of your brother. And we were eager to hear from you in the upcoming CMEs. And with the permission of Kalyani sir, we'll be returning back to the studio, sir.
Okay. Thank you.
Okay.
Good night to all of
Over
you.
to you, Arthur. Good night, sir.
Good night. Good night.
Good night.
Good night.